Hi, everyone. Hello and welcome to today's webinar, Maternal Depression and Anxiety Disorders. My name is Kevin Sanchez, and I'm the Program Coordinator at the McSilver Institute for Poverty Policy and Research, one of the partners of the TTAC project, and I'm so thrilled to be here with you all today. A few logistics about today's webinar before our presenter begins that I want to talk through. First, as we've done in the past, this webinar will be recorded and will be posted along with the slides to the TTAC website. The URL for the TTAC website is TTAC. We'll be taking questions throughout the webinar, and we ask you to chat in your questions using the chat box functionality and selecting all panelists on the drop-down option. We will set time aside at the end of today's webinar to address these questions. And finally, towards the end of the webinar, we will be sending out the feedback survey, our feedback survey using the chat box functionality. We ask that you click the link that is shared in the chat box and complete the feedback survey. We appreciate you filling this out as it allows us to understand your experience and enhance our future TTAC offerings. And with that, I want to thank you for joining us, and I will hand it over to Evelyn Blank.
Thank you so much, Kevin, and I want to welcome everybody to today's webinar. I wanted to briefly let you know about who we are and who TTAC is. And TTAC is the New York City Early Childhood Mental Health Training and Technical Assistance Center, otherwise known as TTAC, which is funded through Thrive New York City in collaboration with New York City Department of Health and Mental Hygiene. TTAC is a partnership between New York Center for Child Development and the McSilver Institute on Poverty, Policy, and Research. New York Center for Child Development has been a major provider of early childhood mental health services in New York, and we have expertise in informing policy, but also supporting the field of early childhood mental health, which we do both through training and direct practice. And we are really pleased to have a subcontractor, NYU McSilver Institute for Poverty, Policy, and Research, who house the Community and the Managed Care Technical Assistance Center and provide ongoing technical assistance and support with a focus on business sustainability. TTAC is tasked with building the capacity and competencies of mental health professionals and early childhood professionals in cross-child serving systems. We would like all of you to join our learning community. I encourage you to go to our website. And Kevin, maybe you can just advance the slides to the website. And this is a screenshot of our website. And we provide ongoing trainings. If you go to our website, you can find out about upcoming events, as well as archived webinars that are all available if you go to past events. So it is now my pleasure to introduce my esteemed colleague, Dr. Susan Chinitz, who is a psychologist with specialties in the areas of infant mental health and developmental disabilities of both infancy and early childhood. She also serves as the clinical co-director of TTAC. She is the former director of the Early Childhood Center, the Center for Babies, Toddlers, and Families, and the Parent-Infant Family Court Project, all therapeutic programs for children birth to 5 years of age at the Albert Einstein College of Medicine, where she was a professor of clinical pediatrics, as well as the Patricia T. and Charles D. S. Raisin Distinguished Scholar in Pediatrics. Dr. Chinitz is currently affiliated with the Center for Court Innovation, where she is spearheading the Strong Start Court Initiative, which is an effort to integrate developmental science into family court practice for infants and toddlers. Dr. Chinitz serves on numerous boards on the 0 to 3 Network, the Community Advisory Board of the New York City Nurse-Family Partnership. She is on the faculty of the Parent-Infant Psychotherapy Program at the Columbia University Center for Psychoanalytic Training and Research. She also previously served on the local coordinating council for the New York City Early Intervention Program and has also been a member of the Frontiers of Innovation Initiative of the Harvard Center on the Developing Child. She has received numerous awards in recognition of her many achievements and outstanding work, including the ACS Commissioner's Child Advocacy Award, the Women of Achievement Award from the Bronx Women's Bar Association, and the Distinguished Alumni Award from the Furkoff Graduate School of Psychology at Furkoff University. So it is my pleasure now to turn it over to Dr. Chinitz.
Well, thank you, Evelyn, for the introduction, and good afternoon to everyone. Oh, and thank you for joining this webinar. I am going to turn on the video just for the introduction so you can see who I am, and following the guidance of a former presenter, I think I'll turn it off for the major part of the presentation and turn it back on again when we engage in questions and answers, mostly because I have to use the phone. It's the better way to get sound, and I don't think you need to watch me talking through the phone. Anyway, I've worked with this group once before, and I've worked extensively with Michelle in the preparation of this webinar, and I'm very happy to be back with all of you. I have a lot of admiration for the work that you do in supporting new parents at one of the most important times in their life, the arrival of a new baby. What you do for families, even in the context of a few visits, has potential to affect 2 generations and even more than that. I really feel very proud and impressed that New York City is providing and even expanding these services. And as an early childhood professional, I'm very appreciative of the efforts you make, whether through in-person visits or via telehealth sessions. It's really important work. Before we dive in, I just wanted to acknowledge the context in which we're meeting, including the COVID-19 health pandemic, which has changed the way we all live, the way you all work, and has led to so many losses of loved ones and so much economic strain for all of us. And more recently, and perhaps more importantly, the collective grief we all feel in response to the tragic and shocking homicide of George Floyd, and the ongoing protests that underscore the need to reform so many aspects of our society that have been oppressive and discriminatory. In this light, I want to again acknowledge that the work that you do affirms that all mothers, all babies, and all families are important and deserve support for their health and well-being, that all are entitled to outreach to be sure that they are coping in good stead at the arrival of a new baby. I'd like to suggest that this check-in and the efforts to connect families of newborns to services and supports is the best affirmation and manifestation of a commitment to equity and inclusion. And just one more word about terminology before we start. Michelle has shared with me the work that your group has been doing to use respectful, gender-neutral, and inclusive terminology in referring to parents. Our discussions have contributed to the growing list of things that I've learned from you, and I've tried to be mindful of that in the preparation of these slides. Wherever possible, I have substituted the word parent or birthing parent for the word mother. However, in this field, so much research has been done specifically on maternal depression that I didn't feel I could substitute for the word mother in certain places where the research, in fact, has been on mothers. I hope you'll understand that when I do use the word mother in a particular context, it's only for that reason, and that I do agree with the decisions your department has made in this regard. Okay. So I'm going to turn the camera off now, and I think it is. And Kevin, I'm trying to, okay, there we go. Okay. Okay, so to review our goals and learning objectives for today, I'm going to spend a lot of time reviewing actually the primary features of depression and anxiety disorders. I'll talk about the impact of depression and anxiety disorders on parents, on young children, and families. I'll talk about screening for depression with the PHQ-9 and screening for anxiety disorders with the GAD-7. I'll try to provide some suggestions about how you can support parents in obtaining intervention when that's indicated. And I hope that we'll have the opportunity to talk about practical issues and home visitor concerns in the implementation of screenings for depression and anxiety. Some engagement around your experience was easier to do when we had this this content presented in person. I'm hoping that the question and answer or chat functions will allow us to exchange a little bit more around your experience doing this, because I know that these screenings often raise questions and concerns. Okay, so starting with depression. You know, we all use the word depressed or depression a lot in our day-to-day lives. That was a depressing movie. I'm depressed, I can't be with my family again this weekend. We say it every day. But depression is actually a clinical disorder, an illness, although a treatable illness. It's not the same as just feeling sad or stressed about day-to-day life problems. Depression includes at least one of the two following symptoms: persistent sad, depressed, hopeless, or empty mood most of the day, nearly every day, and a loss of interest or pleasure in usually enjoyable activities. In addition, depression symptoms include a change in eating habits, either poor appetite with consequent weight loss or increased appetite with weight gain. Similarly, there can be difficulty sleeping or oversleeping. There's often fatigue or loss of energy, and difficulty concentrating, remembering, or making decisions. Depression is as much, therefore, a strain on psychological energy as it is on physical energy. There are feelings of guilt and worthlessness, feeling physically slowed down or feeling physically restless. And in the more serious cases, there are recurrent thoughts of death or suicidal thoughts. To qualify for a diagnosis of depression, a person has to have at least 5 symptoms with at least 1 or 2 of those first 2, which are the persistent sad or empty or hopeless feelings most of the time, and the loss of loss of pleasure in enjoyable activities. So at least 1 of 2 of those and 5 altogether. The symptoms have to be present for at least 2 weeks, and they have to cause significant distress or functional impairment for the person. We're going to talk about functional impairment a lot during this webinar, because that's really how we differentiate between the normal experiences of depression and anxiety and the more clinically concerning disorders. Depression often includes somatic symptoms or body-based symptoms such as headaches or stomach aches or just general abdominal discomfort. But those are not necessary features in order to have a diagnosis. And similarly, anxiety is often part of depression. The two co-occur very frequently, although you don't have to have any symptoms of anxiety in order to qualify for a diagnosis of depression. The prevalence of depression is approximately 9% in the general adult population, and it is significantly more common in women than in men. That's very consistent in all of the research, although people suggest sometimes that that might possibly be due to an under-identification in men, that maybe men's symptoms of depression might look a little bit differently. But for now, we do think it's more common in women. So I thought important to review some terms, because there are many different terms used in this context. When we talk about depression, we're really talking about major depressive disorder. That's the actual official terminology in the DSM-5, major depressive disorder. And that's kind of the general category that I tried to represent on the slide, like the overall, the dark blue, the biggest bucket. I see it's not coming out so clearly on the slide as it is on mine, but it's the overall category. And then there's a subcategory called maternal depression. That is major depressive disorder experienced by anybody who is a mother. Same depression, just qualified in the context of being a mother. And then a subcategory of maternal depression is perinatal depression, and that is depression that begins either during a pregnancy or postnatally in the first couple of weeks or months. So it's divided further into antenatal depression, which refers to depression that begins during pregnancy, or postpartum depression, depression that begins shortly after a baby is born. In DSM-5, which is the official diagnostic manual for psychiatric disorders, perinatal depression is actually called major depressive disorder with peripartum onset. Just reviewing all these terms because they're all used in this context. And then also in the field of maternal and child health, we hear about perinatal mood and anxiety disorders, or PMADs, which are inclusive of both depression and anxiety, but also include some other disorders that sometimes affect mothers of newborns, including postpartum psychosis, which we're not going to talk about today. Okay. So maternal depression is very common. An estimated 10 to 20% of mothers will be depressed at some time during their childbearing years. That translates into the fact that about 1 in 11 infants will experience their mother's major depression in their first year of life. The rates of depression are even higher for women who have had previous episodes of depression, and for the large number of mothers that we all work with who come from low-income backgrounds, have histories of adverse childhood experiences, may be homeless, may have experienced intimate partner violence or other life stressors. It's really not a great surprise that depression is more common in women who have had more life struggles. Recent data indicate that in households below the federal poverty threshold, 1 in 4 mothers of infants is experiencing moderate to severe levels of depressive symptoms. In a study of parents enrolled in WIC in Pennsylvania, depression rates were as high as 38%, and I remember reading Head Start studies a couple of years ago where the rate of maternal depression was almost 50%. So there's a lot of depression in the population of women that we work with. I'm going to mention poor social support, which is in the last bullet of my slide, because poor social support is very highly correlated with the onset of maternal depression. And I'm just underscoring it now since the opportunities for social support for mothers of newborns is so much more limited now during COVID-19. It's a time in our history where we have to keep a greater eye on mothers because their usual sources of social support are often not available to them. I'd like to spend a few minutes to also point out the difference between postpartum blues and postpartum depression. Postpartum blues happen to many, if not most mothers. Some studies show 50 to 85% of women experience postpartum blues. These start a few days after delivery and involve the tearfulness that we might remember from the first few days after we've had a baby, sometimes some mood lability, sometimes some anxiety. But it all remits on its own, usually within around 2 weeks of the delivery, and it's not really an illness. It has to do with the very major adjustments that we need to make as we transition into the role of a parent. And people believe, and I'm sure it's the case, that there are also some hormonal contributions to the baby blues or postpartum blues. Postpartum depression, as opposed to that, affects 10 to 20% of women, as we said, emerges anytime within the first 2 or 3 months after delivery, and involve all the symptoms we just talked about: depressed or irritable mood, sleep and appetite disturbances, loss of pleasure. It is longer in duration, and it's a much more serious clinical disorder. Again, like postpartum blues, people do feel there's probably a hormonal contribution to postpartum depression as well. I made these 2 columns. We've talked about the symptoms of depression, which are on the left side of this slide, but I thought it would be interesting to compare the demands and expectations of new mothers, which I have on the left side, with the symptoms of depression on the right side. And if any of you can remember back to the days when you brought your new babies home, I'm just juxtaposing the symptoms of fatigue and low energy, loss of interest in enjoyable activities, sadness, hopelessness, poor sleep, loss of appetite, social isolation, difficulty maintaining basic level of function, with what we know we all expect and need of new mothers: a loving welcome to a baby, the ability to woo an infant into the wonderful world of people and interesting objects, to establish routines for babies, to be prepared for nighttime wakenings and feeding, to be up for the challenges of breastfeeding, to provide play and stimulation for an infant, while also meeting the needs of other family members. So I think, it becomes a little bit more obvious what an impact depression can have at this particular time in a family's life. There's extensive research on the impact of maternal depression on infants. This is a very robust research base. And the research shows that even, and maybe even especially, very young children are affected by parental depression. Research shows that parents sometimes have more difficulty bonding with their babies when they're depressed, more difficulty establishing routines for the infant, show a lower level of warm acceptance of the baby, are often less engaged with the baby, have less well-timed responsiveness. For example, perhaps the parent doesn't respond to the infant's crying promptly or doesn't return the baby's smile. And they have fewer serve and return interactions, and these are interactions that are very important for brain development. I was hoping to be able to show you this video called Serve and Return Interaction, but it turned out the technology wouldn't permit me to show it to you. I hope that the screenshot that I was able to take of the video illustrates the concept of serve and return that occurs when one person in the dyad, either the parent or the baby, initiates an interaction and the other one returns the interaction. Starting with a smile, the baby smiles at the mom, and then the mom smiles back at the baby, or cooing, the mom might start or the baby might start. But there's a reciprocal chain of interaction that starts around that. Sometimes also called opening and closing circles of communication. This serve and return interaction builds brain circuitry. It's the foundation for subsequent learning and for children's social emotional development. Though I'm not able to show this video, I've provided you with the YouTube link and also the website on which the video exists. It's on the Harvard Center on the Developing Child website, www.developingchild.harvard.edu. It's only 2 minutes, or maybe even shorter than 2 minutes, but really shows how the serve and return interaction works and how it builds brain development. Research has shown that parents who are struggling with depression show one of two kinds of behavior that disrupt these serve and return interactions. Depressed parents sometimes show hostile and intrusive interactions that are triggered by their irritability and by their negative mood, or they show disengaged or withdrawn behavior. Either of these two patterns disrupt the serve and return interaction that's essential for healthy brain development. And in fact, children of chronically depressed mothers do perform lower on developmental, cognitive, emotional, and behavioral assessments and do show higher rates of clinical disorder. I mean, that's multi-determined. It's not just due to the failing of serve and return interaction, but that's considered to be a fallout of maternal depression. And so when we consider the impact of depression on the parent and on the infant, we see highlighted the importance of screening. We know that parental mental health and well-being is very important for young children. We know that maternal depression is a known risk factor in infant and child development. We also know that depression is very responsive to treatment. And so screening is an important preventive intervention that can improve outcomes for parents, infants, and families. Here are some important milestones in the recognition of the importance of screening for maternal depression. In 2010, the American Academy of Pediatrics recommended that there be postpartum depression screening as a part of well baby visits at 1, 2, 4, and 6 months of age. In 2014, Governor Cuomo passed legislation in New York that recommends screening for maternal depression and recommends lots of education and psychoeducation around maternal depression. And in 2015, New York City, through Thrive NYC, announced a goal for 100% screening within 2 years. I don't really know where the city is in progress toward that goal, but I know for sure that we're on our way. The PHQ-9 is one of several depression screeners. It's one of the most commonly used. I know it's the one that you use. It was developed in the late 1990s, and it's very based on the 9 symptoms of major depression that were listed in the DSM-4, which have remained exactly the same in the DSM-5. That's the diagnostic manual that I mentioned before. The PHQ-9 has been found through a lot of research to be a reliable and valid screener that at a cutoff score of 10 shows very good sensitivity and specificity for major depression. In other words, it captures most people who are struggling with depression at a cutoff score of 10, and it also is very specific in identifying depression. It's designed to be self-administered and reviewed by a clinician, but I know you interview will address that soon. It was assessed to be on a 6th grade reading level, and it's available in many, many different languages. Okay, here is this, the scale. It consists of 9 questions that are answered by endorsing that the person has experienced that particular symptom either not at all, for several days, for more than half the days, or nearly every day out of the last 2 weeks. Okay. It's as a screening for major depression disorder. It's not specifically for postpartum depression. It's gender neutral. It can be administered to men as well as to women. So you can use it for fathers who are primary caregivers. It's most widely used in primary care, and so it's really applicable for all adolescents and adults. The PHQ-9 is meant to be self-administered, and that's just so that it's very easily utilized in large primary care centers. It is often done in interview format, which I believe is how you do it, and I think that has a lot of merit. It certainly doesn't detract from the validity of the scale, because some parents will not be able to manage the reading level or fully understand the questions without some help. Some find the rating scale, called the Likert scale, to be a little confusing. And some people actually do, even though research shows that people endorse more symptoms of depression when they're doing it on their own than when they're doing it with somebody else. Some parents, in fact, say that they prefer to review with a provider, especially if there's been prior trust established. Just by way of saying, it was meant to be self-administered just for ease of administration, but it's absolutely valid and perfectly fine, and sometimes extremely helpful to do it in interview format. Okay. It's helpful to explain the screening to parents a bit before you present it. I find it helpful in introducing the PHQ-9 to kind of both normalize this so that parents don't think there's something about them that makes you target them for this questionnaire, that they don't think that you think there's something wrong with them. And I also find it helpful to emphasize the connection to parenting and child well-being, because that reassures the parent that cooperating with this is going to be good for them and for their baby. So an explanation something like, delivery and taking care of a newborn is stressful for most parents. As part of this visit, I'd like to do a brief interview to explore your mood and feelings over the past 2 weeks. This assessment is being done with all new birthing parents to ensure that they are not experiencing postpartum depression and that they are at their best for their baby. I mean, you may have some other way of introducing. I'm just providing that if people want to consider, a way to present it. The 9 questions that can be are scored from 0 to 3, and so the range of responses. The range of responses can add up to any number between 0 and 27. 0 to 4, a score of 0 to 4 is considered to be within the normal range, and 5 to 9 is considered to represent minimal symptoms. Beginning with a score at 10, we're starting to flag people who may have a clinical disorder. 10 to 14 is related to symptoms of mild depression. 15 to 19 is related to symptoms of moderate depression, and 20 and over seem to signal symptoms of severe depression. I know that I don't have to tell you, but I will reinforce this is not diagnostic, it's just a screening. It does show correlation with level of severity of depression at increasing scores, but the diagnosis of major depressive disorder or postpartum depression does require a more extensive evaluation. I know you all know that. After the parent has completed the PHQ-9, you should review it, especially to be sure that all questions have been answered, and quickly add up the score. I usually recommend that practitioners check in about the score just to be sure that there's some validity in the parent's mind as to the results, that they understood the questions, that they responded in a way that really reflects their own self-assessment. So you might want to consider saying something like, when I add up the answers you gave, I see that the total is 3. That number often means that the person completing the form is not depressed. How do you think that matches how you are feeling? Or, when I add up the answers you gave, I see that the total is 13. That number often means that the person completing the form may be depressed. How do you think that matches how you're feeling? If the score is in the 0 to 4 range, which suggests no symptoms of depression, and if this is in line with your usual protocol, you can consider providing psychoeducation by saying something like, now you're more familiar with the symptoms of depression. If you experience more of these in the future, please speak to your healthcare provider. So saying that now you've reviewed these, you know what they are. If you have more of these symptoms, make sure you speak to somebody about them. In the range of 4 to 9, which reflect minimal symptoms, you can consider offering wellness strategies like taking time for self-care, spending time with supportive friends and family, and asking for help when needed. So suggesting to parents in the 4 to 9 range that there are things they can do to try to boost their mood a little bit. For scores 10 or higher, again, that's the beginning of the clinical range. It's important to discuss the benefits of support and treatment. And I know that you, per your usual protocol, that's the point cutoff at which you refer to your social worker. In addition, or until the social worker is able to make contact, you may suggest that the parents make plans to connect with people in their support system, add more pleasant or more physical activities to their routine, try relaxation activities to manage stress, or call or text NYC Well for information and support. The most important thing, let me just start by saying, just to tell you a little bit about intervention, depression is very treatable, but too few parents receive intervention for depression. That's often because depression is unrecognized, or it might be recognized and still untreated, or it can be treated but inadequately treated. So those are different points at which people fall off the possibility of good intervention. So engaging and assisting parents to find effective treatment is a priority, and it's a very significant contribution of the newborn home visiting program. Okay, to give you some idea of what the interventions are for depression, medications are extremely effective for many people, but they're used a little less often in perinatal depressions due to the potential impact of medications on the developing child. Psychosocial, therapeutic, and psychoeducational approaches are used with much greater frequency for perinatal depression, and these include modalities like cognitive behavioral therapy, abbreviated by CBT, and interpersonal psychotherapy is actually an evidence-based psychotherapeutic approach specifically for maternal depression. Therapies that focus exclusively on the parent are effective in reducing depressive symptoms, but research shows that they appear to have limited impact on the development of the young child. And these findings have led to the recommendation of some researchers that therapy should not only treat the parent, but should also focus on the parent-child relationship. So in addition to intervention for depression, it is to the benefit of some parent-infant dyads to also have a relational support. Child-parent psychotherapy is an example of a relational intervention, but there are others. And that's just related to the fact that some people struggle with depression because of very severe adversities in their own lives, especially adversities when they were children. Sometimes the moms who are struggling with depression had less than perfect parenting themselves, and so the parent-child relational services shores them up in areas where they can use some support in addition for the support they need for depression. One of the most helpful and enduring things that all of you can do is provide a lot of psychoeducation around depression. Again, by normalizing the situation so the parent doesn't feel stigmatized, pointing out that as many as 1 in 5 mothers are affected by depression during or after a pregnancy, and around 1 in 10 mothers, regardless of the age of the child. You know, Michelle and I have talked about key messages. Key messages that depression is treatable. Nobody has to feel miserable. Over long periods of time, there are a wide range of treatment options. Consistent with your program protocols, you can provide online or printed resources so parents can learn more about depression, and you can provide guidance on self-care. These are some of the things that are usually listed when we talk about ideas for self-care: connecting with family and friends. We know the importance of social support, taking time to get out of the house, engaging in physical activity, eating well, and exploring resources for added social support. I know that some hospitals where babies are delivered have mother-baby classes, other mother-baby groups, events at churches or community centers, some way for the parent to connect, maybe meet some other parents of young children and have a little bit more social support. And very importantly, as I know you'll all agree, is for self-care is if the mom can do any planning to get some uninterrupted sleep, if there's anyone who can help her in the evenings at least once in a while so that he or she gets some uninterrupted sleep. I think it's important to explain to parents that getting treatment is not just good for them, the parent, but is also really helpful and important for the child or children. It improves parent-infant bonding. It's related to improved child behavior at home and in school. Children show better learning potential in school when they're not contending with a depressed parent. And it decreases the chance of the child having depression and other mental health problems in their teenage years. Maternal depression has been shown to be correlated with child mental health problems in adolescence. Once you've done a warm handoff to the social worker, if the score is 10 or higher, that social worker will do a more in-depth assessment. And just to give you some idea of the risk assessment that has to happen in the context of maternal depression, most importantly, you want, and especially in response to that question 9, you want to dig deep into the question or concern about any expression of suicidal thoughts or ideation. But the social worker also has to assess whether there's any potential for neglect related to severity of depression or child abuse even. Could the mother's depression or the parent's depression be related to domestic violence? And in the more concerning cases, does the parent have any thoughts of harming the infant? Other factors for the social worker to consider, just to keep in your mind, because depression is higher in the context of women who've had lots of life adversities, sometimes treating depression isn't the only thing that has to happen or doesn't even have an effect if some of these other circumstances aren't shored up. Sometimes parents need other home visiting programs that take up after you guys leave off. Sometimes the support of early Head Start. We've mentioned child-parent psychotherapy. And sometimes families need ACS preventive programs or other kind of care coordination or case management. Again, that's more in the domain of the social worker, but just to give you an idea of what clinical thinking has to encompass in these cases. So I know that clients have a lot of concerns when asked to fill out these kinds of forms, although I'm also hearing that parents have been screened so many times that they are getting used to it. But questions that I've heard parents articulate is if they admit to having these feelings or if they seek help, will their child be taken away from them? Are they being judged in a negative way? There's a persistent stigma of mental health problems, I hope getting better, but still facing many communities. Parents feel guilty if they come to think that their mood or problems are affecting their baby, and I'm sure that you can add other things. Again, this is where I was hoping that maybe you would chat in some of your experiences, especially if they're causing any questions or concerns on your part. And I'm sure that you have your own concerns or questions about screening, although screening is becoming a little more commonplace. But I know that when screening efforts just started, professionals who are being asked to do these screenings have concerns about whether they were getting into information that was too personal for the nature of their contact. Was it too sensitive a time for the family to open up these questions? Will parents be resistant to help? Or wondering if parents will actually follow up if problems are identified. So again, I'd love to be responsive to your experiences and to your questions and concerns about screening, so please feel free to let us know what some of those may be. And maybe we'll just take a minute to pause to see if there are any questions before we transition to the anxiety disorders.
Please add any questions you have into the chat box. There's currently none there, but if anybody has some questions, please feel free to chat them in.
Okay, so we'll take a look at that again in a little bit, and I will transition to speaking about anxiety disorders. So there are many, many different categories of anxiety disorders. They all share features of excessive fear and anxiety and the behavioral disturbances that emanate out of this excessive fear and anxiety. Fear is the emotional response to a real or perceived imminent threat. So the fear we feel if we encounter an aggressive dog or in the context of a home invasion, whereas anxiety is the anticipation or worry about a future threat. Like depression, we all feel anxious at times. Anxiety and worry are a normal part of life, but what distinguishes this from normal worry from anxiety disorders is both the severity of the anxiety, the difficulty controlling it, and again, the social and functional impairments that it causes. I'm going to talk about impairments again because that's the level at which we consider it a disorder. If these symptoms interfere with an individual's ability to meet the demands of their day-to-day life, that's considered to be an impairment, and that sometimes is the way we differentiate. Okay, so the GAD-7 was designed to pick up generalized anxiety disorder, so we'll talk about that, but it's also sensitive in picking out several of the other anxiety disorders, so I will mention and briefly describe some of the other anxiety disorders as well. Okay, oops, I did not bounce these. Okay, so starting with generalized anxiety disorder. Generalized anxiety disorder is excessive anxiety and worry that occurs more days than not for at least 6 months about a number of events or activities. There's a lot of things that cause the person to feel anxious. The individual finds it very difficult to control the worry. The anxiety and worry are associated with 3 or more of the following 6 symptoms. Restlessness or feeling keyed up and on edge. For any of you who have struggled with anxiety, and I certainly have times in my life when I have, you know that there's a very noxious sensation in the body. Anxiety is a very physically uncomfortable symptom. The second symptom is being easily fatigued. A third is having difficulty concentrating or your mind going blank. There's irritability, muscle tension, and or sleep disturbance, either difficulty falling asleep or staying asleep or very unsatisfying sleep. And again, it causes impairment in important areas of function. So that's generalized anxiety. It's anxiety that's experienced in the context of multiple perceived threats or worries. And that's specifically what the GAD-7 is designed to pick up. Although not specifically designed, it is very sensitive in also picking up panic disorder. So I thought to describe that to you a little bit. Panic disorder is the unexpected, the recurrent, so it happens over and over again, the recurrent and unexpected panic attacks. A panic attack is when a person has a sudden and unexpected surge of anxiety that lasts for a little while, peaks within a few minutes, and has the characteristics of several of these symptoms that I list underneath. So palpitations, a pounding heart or an accelerated heart rate, sweating or trembling or shaking, sensations of shortness of breath, feelings of choking, chest pain or discomfort. I have to say that a lot of people who go to the emergency room worried that they may be having a heart attack are actually having a panic attack. There's a differential diagnosis between those symptoms because it's a very body-based feeling, these panic attacks. And then they subside, but the severity of them and the unexpected nature of them make people very, very anxious about when they'll have another panic attack. And so that creates its own anxiety, concern about having another anxiety attack, and all of the maladaptive changes in behavior that they are left with as they try to avoid having that experience again. Okay, another anxiety disorder that the GAD-7 picks up is agoraphobia. Agoraphobia is also intense fear or anxiety about 2 or more of the following 5 situations. It has to do with being kind of out and about, using public transportation, being in open spaces or being in enclosed spaces, standing in line or being in a crowd or being outside of the home. Often agoraphobia develops sometimes after a panic attack because the person is afraid about being in these circumstances if a panic attack happens and they have no ability to get help. Sometimes the person is better able to confront a feared situation when accompanied by a companion. So it's not necessarily an outgrowth of a panic attack, but it sometimes is. And I'll say that a lot of these anxiety disorders are comorbid with each other. You can have just one of these anxiety disorders, but sometimes people have more than one. Okay, a specific phobia is an anxiety about a very specific object or situation. So people have specific phobias around flying, for example, or about heights. The phobic object, whatever it is, a snake, whatever it is, exposure to that phobic object almost always provokes immediate fear and anxiety. It's actively avoided, therefore, or it's endured with intense fear and anxiety. Again, like all the other anxiety disorders, the fear and anxiety is out of proportion to the actual danger posed by that specific object. The fear and anxiety is persistent, usually lasting for at least 6 months or more, and it creates a social or other kind of impairment. The GAD-7 is also good at picking up social anxiety disorder or social phobia, and that's a specific fear or anxiety about being in a social situation, particularly the fear of being embarrassed or humiliated or getting the negative evaluation of other people. It's the social situation that's the frightening or anxiety-provoking situation. Okay. Often triggered if the person has any performance or public speaking or is being introduced to a group of new people they haven't met before. Anytime the first person feels that they're being observed or evaluated can provoke severe anxiety in a person with social phobia. Okay, so those are the other ones besides the GAD-7 that besides general anxiety disorder, the GAD-7 picks up. And I'll just mention the other ones just briefly. Separation anxiety disorder is usually a disorder seen in children. And most of us most of us know children who've had some separation anxiety. That's common in children. Separation anxiety disorder is only considered a disorder, again, when it's excessive, when it causes the child or the adult not to be able to do things that they are supposed to be doing, if it's developmentally inappropriate at that point. Selective mutism is another anxiety disorder that we usually see in children. That's the fear of speaking in public circumstances, kids who speak quite well at home but refuse to speak outside of the home. And these others are just other categories, less commonly seen. Medication-induced anxiety disorder due to another medical condition, or anxiety disorders that don't meet any of those categories. I'm going to speak for a second about post-traumatic stress disorder because the GAD-7 also picks up PTSD. PTSD has often been considered an anxiety disorder. In DSM-5, it's taken out of the anxiety disorder category and put into the category of trauma and stress-related disorders. And that's mostly because sometimes fear and anxiety is the prominent feature of PTSD, but sometimes it's not. Sometimes people have more depressive symptoms or more dissociative symptoms. So it was considered not to any longer be best fit in the anxiety disorders. But I think you're all familiar with PTSD. It involves a definite exposure to a traumatic event, something very threatening, a car accident or worse, an attack, sexual abuse, something very threatening. And the symptoms involve one or more intrusion symptoms. That means things that intrude on the person's thinking or behavior, things like nightmares or flashbacks, uncontrollable ways that the trauma comes back into a person's mind. It involves persistent avoidance of stimuli associated with the trauma, so that can be impairing also if the person can't really re-expose themselves to anything directly related to the trauma or reminders of the trauma. And it also involves marked alterations in arousal and reactivity, so people become very easily startled, they become hypervigilant, they kind of see danger, even when danger doesn't exist, just an increase in their arousal and reactivity. Again, the symptoms have to be present for more than a month, and they have to cause significant distress or impairment. Oops. Okay. So there is also a research base on the impact of anxiety on parenting and child development. It is not as an extensive a research base as there is for maternal depression, but there is some research. And I do remember being at a conference. I could not figure out where and who the speaker was, but I do have an image of a speaker talking about that anxiety can even be have a more pernicious impact on young children. I couldn't find that reference, but I do remember him saying that. So I think your program is quite wise and progressive in adding screening for parental anxiety to your protocols. Here's what some of the research shows on anxiety disorder impact on parenting. It may diminish that kind of contingent sensitive response to the infant or young child and cause more negative responses to the baby, or a more amplified, maybe even a more frightening response as the parent is feeling frightened themselves. It's related to diminished parent-infant dyadic regulation. You probably all know how important parents are in helping young children become regulated across so many different domains. And a parent who's struggling with anxiety doesn't really have great emotional regulation themselves, so it's very hard for them to support their baby's emotional regulation. The fearfulness can result in a parent being overprotective of a child, not allowing usual exploration, not allowing the baby to go off by themselves at times that are usually appropriate. Similarly, it can involve over control of a child for similar reasons, out of fear and anxiety that the child's getting into danger or something bad happening. And there's this phenomenon called anxiety contagion. We know that young children use their parents as a social reference to help them understand what's safe and what's not safe and how they might react to unfamiliar situations. So if a parent seems frightened or anxious in very many circumstances, that may make the child feel frightened and anxious. And then combined with depression, a combination of anxiety and depression is associated in the research literature with emotional and disruptive behavior problems in children that are seen starting as early as 18 months of age. And again, as I said before, and also connected to more depressive symptoms in children once they become of adolescent age. Okay, so let's talk about the GAD-7. It was developed by a psychiatrist and has very good validity and reliability. It was validated on almost 3,000 primary care patients. It is also designed to be self-administered. Again, it screens for generalized anxiety disorder, and it also, like the PHQ-9, assesses the level of severity of the symptoms. I mentioned that it's also useful in detecting the symptoms of those other anxiety disorders. It's also available in many languages. It consists of 7 questions that assess the presence of the primary symptoms of generalized anxiety disorder. Like with the PHQ-9, the client indicates whether the symptom has occurred over the past 2 weeks for several days, more than half the days, nearly every day, or not at all. The total score possible is 21. And the last question, I have the scale coming up on the next slide, but the last question is a good indication of the client's level of impairment. So the last question, like on the PHQ-9, does not get scored, but it asks the parents how difficult these symptoms have made it for them to do their work or take care of things or to get along with other people. And and they can rate that as not difficult at all to extremely difficult. And again, that gives us some idea of the level of impairment. Okay, so scores till 9, well, again, like at the PHQ-9, same thing. 5 to 9 are considered mild level of symptoms, and the guidance is just to monitor over time. Scores of 10 to 14 are considered yellow flag scores, drawing attention to the possibility of a clinically significant condition. And scores of 15 and over are considered red flags, targeting individuals for whom treatment is probably indicated. That's a point at which I guess you guys would do the warm handoff to your social worker. Interventions for anxiety, again, the psychopharmacology medications are often used for anxiety disorders, but medications take the edge off the symptoms. They reduce the feeling of anxiety, but they don't cure the anxiety. Psychotherapeutic approaches, again, cognitive behavioral approaches in particular, have been found to be very efficacious in working more toward a resolution or cure for anxiety disorders. Okay, so we're getting close to the end. I'm going to be working a little bit more with Michelle on key messages, but the key messages that I wanted to underscore are that depression and anxiety are very, very common in general, and especially for parents of young children, and that they often co-occur. Though my slides do not really emphasize this, they really often occur together, or at least some symptoms of one is usually present in the clinical disorder of the other. Again, between 10 and 20% of women, that's a lot. That's 1 out of every 10 or 1 out of every 5 to 10 women will be affected by one or both of these disorders sometime in their lives. The birth of a new baby is obviously a joyful but also a stressful time and can be a trigger for these disorders, either related to hormone shifts or just the adjustments necessary, or the things that a new baby triggers in the parents' memories of their earlier life. Depression and anxiety can adversely affect mothers, children, and families, but there are many effective treatments for both, and that treatment will benefit both the mother and her child or children. We have listed some resources, including New York City Well. There are many sites of resources specifically around maternal depression that are indicated here. On this slide, the next slide, I wanted to highlight the New York City Early Childhood Mental Health Network, of which we are a part and which is mandated to serve children birth to 5 years of age and their parents and families. So those clinics are a good resource for getting help. And New York City has a very specialized program. I'm sure it's not the only one, but it's a very interesting one called the Motherhood Center. I've worked with them. They specialize in perinatal mood and anxiety disorders, and they do a lot of free professional development. Sometimes they offer, they've had many lectures that I've attended that are free of cost. I don't know what's happening if they're doing them virtually now, but that's a really good resource for not only clients who might need support, but also for everyone's professional development. So that brings us to the end with time. In case there are any questions or anything that anyone wants to talk to me or each other about.
So Susan, thank you. That was so informative. And I really encourage people, please fill out the evaluation, which you'll find the link to that in the chat box. And again, there are no questions right now, but if anybody has a question they'd like to raise, please chat it in. We'd be very happy to kind of respond. I thought this was so informative. Thank you, Susan.
Okay, and Michelle and I will be talking early next week, so if there's anything you want Michelle to bring up or to ask about, we will definitely be reconvening on Monday.
Terrific. So we'll wait just another moment. I thought this was extraordinarily helpful. Well, I don't see any questions coming in, but I would suggest that people do have questions. Maybe they can let Michelle know, and we'd be happy to respond to them. And thank you so much. This was so practical and so informative. We really appreciate it. Thank you.
Okay. Thank you again for all the work you're doing. It's really such important work, and we really we respect it, and thank you all for it. Okay.
Okay. Take care. Be well, everybody.
Bye-bye. Bye-bye.